Hello. Let me try my Romanian. Bună dimineața.
Oh, good morning.
Okay. I am super honored to be asked to come and lecture and give you a little talk about geriatric trauma. I've never been in Romania before. I'm just so pleased and so happy to be here. The Romanian people are so warm and so welcoming, and I'm so grateful to be able to have this opportunity to try to teach a little bit. I'm going to talk about geriatric trauma a little bit, and I just want us to learn to think about geriatric trauma a little bit differently. So, I'm Alice Lee, Dr. Alice Lee, and I'm a clinical assistant professor at the University of Arizona College of Medicine in Phoenix, Arizona. And I mostly work in a community hospital in a retirement community. So my experience is with taking care of more retired and elderly people. I also have a blog. It's called iCubed. You can find that online. And it's just presentation of real cases that I have. And I try to teach how you think about different types of patients, okay? But before we go into this subject, I live in Arizona.
Oh.
Yeah? And we are well known for our very famous cactus. It's giant. This cactus is about 10 feet tall. 10 feet tall. It only grows 1 inch a year. 1 inch a year. So this tree is hundreds of years old. It's called a saguaro cactus. You have it all along the streets, and then every May it has flowers. This is the University Hospital, this is the Arizona College of Medicine that I work at, part-time a little bit. A few times I teach the students. But my main job is here. I work as an emergency physician in a geriatrics, mainly geriatrics area. There's 421 inpatient beds. There's 50,000 emergency department visits every year. More than half are older than 65. A few percent pediatrics less than 18, just a few percent. And we have a very high admission rate because it's senior citizens, right? 40% are admitted. That's very high, very, very high. Okay, so I have a few goals today I want to try and reach. So number one, I want to present a general idea, an overview of geriatric trauma, because geriatric trauma is a different breed of patients, okay? Number two, I want, through this lecture, to increase everybody's awareness and appreciation and vigilance of geriatric elderly trauma, okay? And to do that, I'm gonna use specific cases that I have had to show you, to demonstrate and help you remember, okay? So, what is an older adult? Anybody know? What's an older adult? I guess this is a very famous Romanian physician. So generally we think of an older adult as someone that's older than 65. Typically, usually what we think. Now, geriatrics or older patients are not just gray hair adults, okay? So this plus this does not equal this, okay? You understand? It's not the same, not the same, right? So older adults are unique in that they have different unique physiology. So as you get older and older, your physiologic age and resilience and reserve gets lower and lower. Here, 30, it's very peak. Those of you who are 30, this is it. This is max. You're gonna go down from now, 30, all right? So, just a few statistics. Trauma, at least these are statistics from the US, just, I should remind everybody, this is all information that we're getting from the US. So trauma is actually the 5th leading cause of death in the seniors, in the elderly, or the retirees. At the time of this study, which was back in 2006, so quite a while ago, the more than 65-year-old patients were 12% of the population, but they were responsible for 28% of the trauma deaths. So much more percentage, a higher disproportionate amount of deaths from trauma of the elderly. So here are some more numbers to illustrate that. So this is data from 2013 or 2010. So we have, back in 2010, we have 40 million greater than 65-year-old in the population. 40 million, that was back in 2010. It was anticipated that you will have 20% of the US population older than 65, and that's 70 million older than 65. And the last statistics I saw was from 2019, and it's greater than 65-year-old people in the population will be 16%. It was actually back, 3 years ago. The U.S. population consisted of 16% older than 65. Okay, so just some quick things here. So back at 2013, we had 13% of the population that was older than 65. 15% of the emergency department visits were older than 65. 35%, 1/3 of all the emergency ambulance were by the seniors, and then 40% admission from the ER with the seniors, with 50% of the hospital critical care patients who were older than 65. And it's anticipated by 2030 that 20% of the population will be older than 65, and then 23% of the ED, 25%, a quarter of the ED arrivals will be older than 65, and then the ambulance traffic to the ER will be 50% will be from 65-year-olds. All right. So this is the U.S. population, just very simple percentage. So most of the population is somewhere between 14 and 64. So 17% or so, 16%, 17 in the U.S. are older than 65. I looked at the statistics from Romania. Very much alike, very, very similar, very similar. So most of the admissions for trauma are because of falling in the senior citizen. 75% of those admissions of those elderly people, they get admitted because of falling. Not because they're out skiing, they're not out, bicycling and racing, they fall. They just fall, right? Ground level fall. So just a few little bit more of a statistics. So there's about 1/3 of seniors over 65 in the community that live independently will fall every year. So like if you look to the right, to the left, There's 3, 1 will fall every year. Someone who is 65 or older, who lives in the community. And then half of 80-year-old and older will fall every year. It's a lot of falls, a lot of falls. And the mortality of the seniors, the number 1 cause of trauma-related mortality in senior is falling. Yeah. So why do seniors fall? This is my mother. She's 86. She's a demonstration of all the problems that old people have. They walk slowly, they have a cane, they can't hear you, they can't see well. So this is my mother and I on a cruise recently, and she's walking with her beloved cane. It's actually an umbrella. Okay, so why do they fall? Oh my goodness, there's so many reasons for why they fall, right? One is they have an acute illness. They get a cold, they get a cough, they get weak, they fall, yeah? They have cognitive impairment, so they're a little bit disoriented, they're not quite sharp. That's a reason. Then they've got multiple medications. They've got Lipitor, they've got metformin, they've got insulin, they've got this and that. So there are many medications, right? They have less balance. Seniors have less ability to stay in balance, right? They've fallen before and makes them more at risk for falling again. They have sensory deficits. They can't hear, they can't see, they bump, they fall. Right? They also have alcohol use, which surprises me all the time when a senior citizen has an alcohol level in their bloodstream. But I think we underappreciate how much this senior citizens actually will drink. And that affects their balance, their judgment, right? Postural hypotension. So people, elderly, are more prone to postural hypotension or orthostatic hypotension. They get up, blood pressure drop, they fall. There's medications that cause that, Parkinson's medicines that cause that, beta blockers will cause that, right? Senior citizens have depression. I think we underappreciate depression. I think many seniors are isolated, they're alone, they have family, but they're far away. So depression has, and they have illnesses, chronic illnesses. So depression plays a role. And then they, like my mother, uses an assistive device, her own, that she chose, is an umbrella. But many others have walkers, right, or electric walkers and things. And they sometimes are an impediment, and they actually cause falling, right? And then environmental factors, multi-generation houses. There's the children with the Legos on the floor and the train over there. Grandma walks by and steps on the Lego and falls over, right? So environmental, they don't have bars, right? The bathroom doesn't have a bar. They slip, they fall, they can't grab onto anything. So these environmental factors also contribute to why they fall. So these are the main types of injuries the seniors suffer when they fall. Number 1 would be lower extremity injuries, like hip fractures, very common, right? Hip fractures. Number 2, I don't know why they grouped it, but it's neck and trunk fracture. That's the second largest number of types of injuries from falling. And then number 3 is the intracranial head injury. So, I want to talk about and demonstrate that these 4 different types of direct injuries. First one we'll talk about is a hip fracture. Next one will be neck trauma. Next one we'll talk about chest trauma, and then head trauma. I just want to illustrate what these, with real cases, details of what happens and what you find and how do you assess them. So first thing, I saw this patient just 2 weeks ago in the emergency department. She's 81, very, very bright, mind is clear, pretty healthy. She has a little bit of hypothyroidism. She was getting ready for church with her husband. She kicked the side of the curb, getting on the curb, kicked it, fell onto her left hip. She wasn't drinking, she wasn't confused, she just kicked the side of the hip. It was very painful for her to stand up and transfer into the bed. And when I examined her and rotated, moved her leg, it really hurt the hip. So you see the x-ray, where you find what's wrong? Which side is wrong? Left side. Thank you, Dr. Anthony. Do you see the fracture? Very subtle. It's very subtle. This is where the fracture is. There is a sharp angle here, and God did not make our hips have a sharp angle. Here, oops. Here, you see how nice and smooth that is? Here, it's doop, doop, 90 degrees. All right, so hip fracture demographics, the mean age of hip fractures at 80 years old, that's the average age, and mostly are women, 80% are women. I was really surprised when I read this, 16% 1-year mortality. So out of 100 senior citizens that break their hip, by the end of the year, 16%, I even read 20%, 16 to 20% of those hip fracture patients would be dead. I was very surprised, very high mortality rate. Why? Why do they die? Because they have medical complications, right? They have different physiology. They have delirium, they have pulmonary embolism, they have DVTs, they have pneumonia, they have MI or CHF, urinary retention or UTI, a kidney injury, anemia, decubitus ulcers, right? That leads to other things, right? All right, so that was my hip fracture patient. We talked about that one. Let's talk about this one, neck trauma. Neck trauma. So this guy, nice guy, he's 78, also very sharp. He has a little diabetes, and he's got a little peripheral neuropathy. When I see him, he had just fallen an hour and a half before he came to the ER. So at home, he's in the bathroom, he tripped. He kind of slammed his head and his neck against the wall. Didn't pass out, wasn't on any alcohol. When I see him, he's sitting under the bed and he's got a collar on, and he's like, a lot of pain, right? His shoulders hurt, his neck really hurt. Like I said, he didn't pass out, and he's not on a blood thinner, he's not on an anticoagulant, so that's good. I examined him, and he's very conversant, he's very clear. He told me good, clear history. His neck is just killing him in the back of his head. His hands are a little bit weak, and they're really tingly and they hurt. You barely touch him, and he's like, You don't touch hard, you just touch a little bit, and very tingly. And I thought, that's something not normal about that, So we CT his head, of course, and CT his neck. No abnormalities. Normal CT of the head, brain, normal CT of the neck. So what do? What do you think? Send him home? Send him home with a collar? Smart. No, don't ever do that. The nurse said to me, Dr. Lee, the patient scanned his back, it looks normal. Can we send him home? I said, no. You treat the patient that you examined, You don't treat the CT scan. I have said that hundreds of times. You treat the patient, you don't treat the test. That's very, very critical. Examine the patient, treat the patient, and decide how relevant your studies are. So this guy, his hands were weak. He's very, very sensitive hands to touch. Severe neck pain. No, we need to go further. He had a little hematoma at C5 and 6 because the ligaments were disrupted. So when they were disrupted, it bled a little bit, and the hematoma pressed on the spinal cord. And it's central cord syndrome, which is classically upper arm weakness and paresthesia. That's exactly what he had. Right? All right, so what do we do for him? Transfer him to neurosurgery center. He, the surgeon's note wrote, cut the posterior dura, and the hematoma opened up and came out. They did a laminectomy, and he did very well. He did very well. Okay, so I'm being signaled. So hip fracture we talked about, neck trauma we talked about. Next one, chest trauma. Another old guy. But this one's very frail. He's 84. He uses a walker, got hypertension. He fell in the bathroom. He just lost his balance in the bathroom and he fell against the toilet. Yeah, just poof, right against it. Really painful. Barely, a little bit of crunchy. Okay, something's not right, huh? He wasn't on a blood thinner, he didn't pass out, he didn't have any alcohol. You see it? Very frail. I touch him. You see what's wrong? There's a rib fracture there, and there's a rib fracture there. Is that all? The old guy, he just fell against the toilet. It's not like he got thrown out of a car, right? I am a little smarter than that, so I CT'd him. 6 rib fractures, 5, 6, 7, 8, 9, and 10. He has a flailed segment. 6 and 7 are fractured, 2 spots on each of those ribs. Pneumothorax, pulmonary contusion. So we transfer him to a level 1. My hospital is a level 3 trauma, so it's like, you know, not great trauma care there. So we've sent him there. So when you think about an elderly, when you think about trauma, chest trauma, so kids with chest trauma, you get to think differently than an adult with chest trauma, older person with chest trauma, and a very old person and frail person with chest trauma. They're very different buckets. You have to think about them differently, how to work them up. Okay. Rib fractures, mortality is 5 times higher in the older person. Okay, so each additional fracture increases your risk for death by 27%. You can see here that you've got a high rate of pneumonia when you had about 5, 6 ribs on the elderly and the 64 and above. When you have more than 6 fractures, this is a younger person, and this is an older person. 50% will have pneumonia. Mortality, similarly, 5 to 6 rib fractures, the elderly will have more chance of higher mortality, almost 40%. And then at greater than 6 rib fractures, the seniors will have more than 60% mortality. Like, yeah, it's remarkable how much higher. All right, so we talked about hips, we talked about the neck, my guy with the neck. We just talked about the chest trauma from falling against the toilet. Last one, head trauma. This is a good one. So she's 77, she's a happy retiree. Hey, history of hypertension, COPD, she has chronic atrial fib. She was drinking, well, you know, she's retired, right? You know, might as well have something to drink. She went to get the mail outside the house. She tripped, and she fell down on her face. Right? She's taken to Pradaxa. Yeah? It's a blood thinner. It's not used very often anymore. So I examined her, and she's very clear. She's talking clear. She's like me, clear. Speech, mine is sharp. Her left cheek, all around here, bruised, purple and blue, all around. Her eyes are closed like this, purple and blue. I peel open the eye a little bit to look under there. And I had her look up, look over, down, look up. When she looked up, she saw double. Her alcohol is 217. In the US, 80, you can get arrested for drunken driving at 80 in the US. This lady, talking like me, sharp mind, alcohol 217. I was shocked. I was shocked.
Good liver.
Good liver. Good liver, yeah. I was shocked. I was really surprised. All right, so what do you think we found on her CAT scan? How many findings, abnormal findings, do you think? Anyone guess? How many findings that? 1, 2, 5. Oh, you're a smart one. Almost 5. Number 1. This is why she saw double. Because she has a fracture right here on the bottom of the eye orbit. And then her orbital muscle, inferior orbital muscle, is trapped right here. So when this one moves, stay down, and this one goes up, you see double. Because this eye get caught in the fracture. Right? See that? So this, number 1 was a fracture. Number 2, the fat pad was caught under here. Subdural. She had a subdural. She had a subarachnoid bleed. So she had blood in the ventricle. A subdural is blood on top of the brain. A subarachnoid is blood inside the spaces of the brain. Number 5, she had contusions. Her brain was bruised. Different places. Almost right. Number 6, she had midline shift. Only 3 millimeters, but it was abnormal, right? So what do we do? We gave her Praxbine. That's the reversal agent of Pradaxa. And then we sent her to the trauma center, and she was seeing neurosurgery, ophthalmology, and plastic surgery. No surgical intervention. She did very well. So TBI causes, main reason for the young one to have TBI is 23% of falling, right? Just falling. So falls and then car accidents for the young people are the main reasons for TBI, traumatic brain injury. On the elderly, or the retirees, number 1 reason for trauma, head trauma, is falling down. 75% of the head traumas in the elderly from falling. And just a little bit, 8% from car accidents. So the young less than 64 who have trauma, head trauma, I mean. 24% of them get hospitalized, versus a senior citizen, 2/3 of the head trauma will get hospitalized. The young person less than 64, only 5% of them, I don't mean that. 5% will die, the younger ones, from head trauma. Seniors, 10% will die from head trauma. Again, when we think of the different groups as buckets of trauma, head trauma, right? The child with the head injuries, you gotta think differently, evaluate differently than the adult with head injury. And then the older adult with head injuries, different. And those, like this lady on an anticoagulant, you gotta think very carefully. My advice is just scan all the elderly that have a blood thinner and they have head trauma. So let me just try to wrap this up. So what do? We can't, it's very complicated how to prevent falls in the seniors, right? We can't put everybody in a bubble wrap and send them home so they don't fall and break anything. And we make everybody use a walker. My mother refuses to use a walker. Absolutely will not. So the general message in terms of preventing falls in senior citizens, really it is a team effort. It really is. And so quickly, let me just go through it. Acute or chronic illnesses, you really have to establish good relationship with the primary doctor who can follow the patient along, okay? Cognitive impairment, you can maybe refer to neurology, psychiatry, psychology. Polypharmacy, oh boy, that's really difficult if you have a geriatric pharmacist who can sort through all the medications. Decreased mobility, neurology evaluation, and physical therapy evaluation. Fall history, primary doctor will keep a long-term relationship and is aware of how susceptible somebody is to falling, right? And then optometry, audiology evaluation. Alcohol use, yeah, that's a hard one. It's a hard one, but you have to be aware that if your patient, senior citizen, is drinking or not, because that affects their ability to fall or likelihood to fall. Postural hypertension, again, you have to review the medications and see what you can do about decreasing the chances of postural hypertension. Depression, difficult one to do, again, to take care of, but counseling, psychiatry is helpful. And then use of the assisted devices, orthotics, physical therapy can make their recommendations. And then home assessment, a lot of times the paramedics go in to pick up a patient and they see the homes or a mess or whatever, that the homes can be more safeguarded, you know. All right, so today I hope to give an overview of geriatric trauma so you understand how to think about geriatric and some of the statistics. And then we looked at detailed aspects of 4 of my own patients that demonstrated the different types of common geriatric traumas. And then I really hope that I've increased your vigilance and your appreciation for geriatric trauma because they are a very different breed of types of patients. I got a lot of a lot of slides from Dr. Shenvi. She has a really terrific podcast called GEM, G-E-M, Geriatric Emergency Medicine, and those are her credentials and her information. For me, if you want to hear any more from me, I have a blog called iCube. It's on emergency medicine news. You can find me on Twitter. You can harass me there if you want. And I like writing, and so I'm on Substack. There I'll share more about my personal feelings, my faith in God, how that affects my practice as a physician. I've been an emergency physician for 30 years. And I couldn't do that without the Lord. And all of my educational materials in the YouTube channel. So I have many more other things on there that talk about patient care. So if you want to search for AZER Doc Mom on YouTube, you can find all of my lectures and my little demonstrations there. So thank you very much once again.